Hi, everybody. We'll give this another couple of minutes, but you're in the final webinar of the Housing First series that we've been doing for the past 16 weeks.
Yep.
We'll just wait for a couple of minutes and then get started. All right, we'll just give it one more minute. All right, let's kick off. So like I said, this is the 8th webinar in the Housing First series that we've been doing for the past 16 weeks. We've gone through all the other principles that I'll tell you a little bit more about later if you missed them. And today we'll be talking about harm reduction. So we'll just go to the next slide. First of all, we'd like to acknowledge the traditional owners of the lands that we're meeting on today. Eleanor and I would like to pay our respects to elders past, present and emerging, and to any Aboriginal people who may be here today. We're both presenting from Gadigal land. I want to acknowledge that sovereignty was never ceded and that this always was and always will be Aboriginal land. So my name's Alice. I'm the team leader of the Together Home program at Newtown Neighbourhood Centre, which is a Housing First program that works with people with rough sleeping experience and provides support to them as they enter housing. And then Eleanor.
I am a case manager with the Be Mild Women's Foundation. I previously was an intensive case manager with Housing First in Dublin, Ireland.
So this is a webinar, so your cameras are off, your microphones off, so you don't have to worry about that. But we do have the chat box function, and Trish is going to put in the link where you can watch this webinar and other webinars, as well as a feedback form that we'd really appreciate you guys filling in. There's also a Q&A box, so if you have any questions throughout the webinar, please just chuck them in there and we'll answer what we can at the end. So like I said, over the last 16 weeks, we've gone through all the different principles of Housing First Australia, and those are that everybody has a right to a home, that housing and support are separate, choice and control, flexible support for as long as needed, active engagement without coercion, recovery-oriented practice, social connection, and now, finally, harm reduction. If you are interested in any of those, I'd really recommend going back and watching them if you haven't already. And this one, like I said, will be online after this as well. So, harm reduction. Put simply, harm reduction refers to the minimisation of negative impact of potentially risky behaviour. Harm reduction involves the provision of practical strategies and education where it's appropriate, so someone is able to make informed choices. These strategies could include ensuring someone has access to naloxone if they take an overdose, or has access to clean needles or pill testing at festivals. In Housing First programs, the onus for harm reduction falls on all of us, on the policymakers, the support providers, the housing providers, people involved with program design at any level, as well as the actual people that we work with. What harm reduction doesn't involve is judgment on the part of the support provider or requirements involving abstinence from risky behaviour. We know that abstinence requirements lead to worse long-term outcomes for the people that we work with, and we know that people are less likely to be honest with their supports if they feel they're being judged or even engage in support at all. Our job as support providers is to ensure that the people we work with feel safe and able to discuss their behaviours and any concerns they might have around them to facilitate them meeting their goals. Some people we work with may never abstain or limit their drug use, and part of harm reduction is ensuring that we agree that that's okay. Ideally, within a Housing First program, a harm reduction framework is well implemented and housing and support will not be contingent on sobriety. We know that often in programs this isn't the case. We can see it in emergency accommodation that has a strict policy around no drugs or alcohol on site, or with community supports that aren't allowed to see people if they believe they're intoxicated. These policies exist for a really good reason, to keep workers, participants and the community safe. In some ways that's harm reduction in and of itself. But if we really want to house people and ensure that they stay housed, we need to look at it in full. So are we only talking about drugs or alcohol? The short answer is no. The slightly longer answer is that there's a million things we all do every day that minimize our risk of harm, and there's a million things we do every day that don't. We wear sunscreen so we don't get skin cancer. We put seatbelts on so that we're safer in our cars. We use condoms to reduce our risk of unwanted pregnancy or STIs. And we drink water so that we don't shrivel up. On the other end of the spectrum, we also eat bacon even though we know processed meats increase our risk of cancer. We cross the road when the light isn't green because we think the gap between cars is big enough. We have that extra glass of red wine on a Friday night even though we know the health benefits ended 2 or 3 glasses ago. The common link with all of these things is that they're all choices and that we're all entitled to make those choices. In the context of harm minimisation and Housing First programs, there's also a lot of behaviours with the potential for risk that we can apply harm reduction strategies to. There's the obvious drugs or alcohol, but there's also things like non-suicidal self-injury or gambling or medication mismanagement. There's risk associated with living in a hoarded or squalid environment. Importantly, though, there are strategies that we can use that ensure choice and autonomy on the part of the person we're working with, but also allow for increased safety. A good example that I think about regularly when I think of harm reduction is that when I was in my first job out of uni, I worked with a person who would regularly cut herself on her arms or legs as a way of regulating herself. After this person disclosed this to me for the first time, I ran to my boss. I was freaking out. And I was really worried that I had to call an ambulance because she was going to end her life. My boss asked me, has she been doing this long? And I said, yep, since she was a teenager. My boss asked me, has she ever been hospitalized? And I said, yeah, once. She got a staph infection from using a rusty blade after her parents confiscated her razor. My boss said, would you say she has strategies in place when she does this to ensure that she's safe? And I thought about it. She had a first aid kit. The cuts that I saw were well looked after and wrapped up. She was working with a psychologist to increase her capacity to use other regulation strategies. And she hadn't actually expressed any intent to end her life, even though we'd talked about it. This person that I worked with was implementing harm reduction strategies already, and my reaction of panic and catastrophizing wasn't helpful to her at all. From then, if she disclosed to me that she'd cut herself, I would ask her if her wounds were clean and if she had enough first aid equipment, if she felt she needed more intensive clinical support to keep her safe. Her engagement with non-suicidal self-injury was a symptom of the larger issues she faced rather than the issue itself, and learning to treat it like that benefited our relationship and her long-term outcomes. So according to Australia's Housing First principles, there are 4 main pillars of harm reduction: safety, education, change, and inclusion. Safety refers to proactive strategies that assist people to reduce the negative impact of risky behaviours, like the ones that I discussed earlier. That list is never ending, and you'll hear a lot more before this webinar is done. Education refers to our obligation to ensure that people have factual, relevant information that can inform their choices. Importantly, it also refers to this information being provided in a non-judgmental and relevant way. For example, saying to someone, you should really quit smoking, doesn't provide any information that person doesn't know, and makes it pretty clear that your opinion of them is shaped in some way by their nicotine dependence. Change refers to an acknowledgement that we're all ever changing and that recovery isn't linear or doesn't necessarily require abstinence. Change does often require assistance from supports, including referral to specialist services and provision of services that are appropriate to a person's circumstance, culture, and preference. And finally, and very importantly, inclusion refers to the importance of housing and support not being contingent on a person's abstinence from high-risk behaviours. Abstinence or recovery may be, and often is, the flow-on effect of working through other factors that may have contributed to rough sleeping experience, but it's not the goal, and it's certainly not a prerequisite. Now, I'm going to hand over to Eleanor to talk through some of the practice implications of harm reduction and policy shifts we've already seen in this direction.
Thanks, Alice. Yeah, so now we've talked about harm reduction as the definition and its principles. We can look at some examples of harm reduction in practice, as well as how implementing harm reduction practices in a housing first context can be affected by wider scale policy and practice. So changes in legislation and policy around drugs tend to have the most direct effect on the day-to-day lives of vulnerable people, including those we might work with in a housing first tenancy. Housing First, after all, was a model originally set up as an evidence-based practice intended to serve chronically homeless individuals with co-occurring serious mental illness and substance use disorders. So we all know that in order to implement harm reduction practice properly, it can be elevated by legislation adopting a health-led approach. As such, for the next few slides, I'll focus on what harm reduction might look like for those in a decriminalised versus criminalised setup, kind of specifically focusing on drugs. So a major part of eligibility services across Australia is the requirement to be clean and sober, as Alice was discussing. For people who use drugs, stigma and discrimination are public health issues, creating barriers precisely where more support is needed. So some examples of harm reduction services include peer education programs, medically supervised injecting rooms, and needle exchange programs. Harm reduction services being equipped to address these gaps as non-judgmental and having a community-based service delivery is among the core principles of harm reduction. So let's look at how some countries have adapted policies that align more with the harm reduction approach. So first of all, we have Portugal. Portugal decriminalised the public and private use, acquisition and possession of all drugs in 2000, as long as they do not exceed the amount required for an average individual's use for 10 days. This approach focused on public health rather than public order priorities. And if someone was caught with drugs, rather than being arrested, those caught with a personal supply might be given a warning, a small fine, or told to appear before a local commission, which might include a doctor, a lawyer, and a social worker. And at that, they're given some advice about treatment, harm reduction, and the support services that are available to them. So under the Portugal drug policy model, arrests for drug offences halved, HIV infections among people who inject drugs reduced drastically from 1,575 in 2000 to just 78 in 2013, and there was a fall in drug-induced mortality. So talking about Vancouver, so in a move to reduce opioid overdose deaths, Vancouver brought in their first legally supervised drug injection site in 2003. Vancouver pioneered a policy of safe injecting centres, and a 2014 review concluded that safe injecting centres reduce overdoses and increase access to health services. One study found that a 26% net reduction in overdose deaths in the areas surrounding a supervised injection site in Vancouver compared with the rest of the city. And services at these sites include emergency response to overdose, injection related first aid, assessment and referral to primary health care, harm reduction counselling, exchange of needles and other drug paraphernalia, and condom provision. So this site supports users to seek counselling, detoxification and treatment for addiction too, if they wish. And if you're currently working in a service where less of a harm reduction approach is taken, you might have experience with some of these practices on a bit of a lesser scale. So maybe some condom provision or a referral to treatment services. An example where some smaller steps are taken at a policy level is in Scotland, where, as you might know, Housing First received quite a bit of funding in recent years, and they implemented a contact assessment model. Under this model, frontline staff and police officers in service centres and police stations have undergone specialist training to make an enhanced assessment of threat, risk, harm and vulnerability for everyone who comes into contact with the police service. A key component of the model is to review and assess their current demand and give a lot more consideration to instances where the needs of the caller or whoever is coming in contact might be best served in a referral to a partner agency or health service. Again, it's a small step within a criminalised setup, but it's a step in the right direction. And as we often hear, many aspects of successful housing first tenancies are reliant on change in a wider context. So the harm reduction legislation changes in the countries we just discussed means a much more collaborative approach between tenants, police and healthcare providers, and results in a much more cohesive setting for housing first tenancies to thrive. So now that we've talked about countries that have adapted policies towards more of a harm reduction approach, we can take a quick look at an example of how spending has gone in terms of drugs in countries that have adopted a historically criminalised approach. The data above reflects Australia's spending on drug policy in 2016, and as you can see, harm reduction had not been prioritised. So hopefully through ongoing advocacy and evidence-based results, we're hoping that the graph and numbers in that data will change. So the effects of policies and spending like this on someone struggling with addiction in a housing first tenancy are obvious. The less accessibility there is to treatment and harm reduction services there is, the more likely someone's tenancy will be put at risk. So just to finish up, I thought I'd quickly touch on what a gold standard might look like in terms of harm reduction, and that's legal regulation. So while decriminalisation is great and it means criminal charges won't be applied to someone who might be in housing first tenancy who's found to have substances on them, legal regulation would remove all penalties for possession and personal use of a drug. So decriminalisation isn't a single solution, and success depends on investments in things like drug treatment and support services. However, under legal regulation, regulations can be established to manage where and how the legal drug can be produced and sold in the same way that might happen with alcohol. So a proposed idea in implementing legal regulation is that drugs would be legally available, but under a system of government control. And what that might look like is that stricter regulations would apply to more harmful substances like opioids, whereby a prescription may be provided by a qualified GP and then consumed in a supervised setting. For drugs that might be consumed in a more recreational setting like ecstasy, a pharmacy type service could be offered with health and safety restrictions in place, such as license requirements for providers. And look, it's really likely that we are far away from the legal regulation of drugs, but it's important to reflect that this can absolutely happen in the same way that it has for other drugs such as alcohol and caffeine. And while we don't, unfortunately, have some real life examples of what it might look like alongside a housing first tenancy, judging by the success so far of harm minimisation within housing first tenancies, you could bet it would result in even higher rates of housing first tenancy success. So Alice is going to talk you through a little bit what harm reduction might be like on a micro level, and in an environment without policy change, how might we practice harm reduction?
Thanks, Eleanor. So Eleanor covered a lot about what we know helps implement an environment more conducive to harm reduction on a national and international level, as well as policies that both enable and disenable harm reduction on an organisational level. But what can we do as workers in this space to implement harm reduction in an environment without these policy shifts in order to create services more in line with housing first? A large part of harm reduction revolves around a mindset shift regarding risk. Risk assessment and management is a vital component of any service or organisation, and we'll always need things in place to manage risk to workers, service users and the community. But we should also remember that our duty is to empower the people we work with and prioritise their autonomy. If our mindset as workers, working within our guidelines, of course, prioritises this, you'll find that harm reduction is a natural flow on. If our reaction to someone disclosing risky behaviour is to immediately try and assist them with abstaining from it, we risk that person totally disengaging, which is a worse outcome in the long run. Rather, we should be looking at situations involving risk as dynamic and individual. Certain behaviours don't equal bad outcomes, just like other certain behaviours don't equal good outcomes. And regardless, it's not our place to decide either way. Again, it's really important to work within our organisational guidelines, but we do need to remain flexible with our individual approaches. An example of this could be creating safety plans with the strong likelihood of substance use in mind. Let's be real, if someone doesn't want to stop using or drinking or anything like that, a strong word from you isn't going to force them to. And so abstinence as part of a safety plan just isn't realistic a lot of the time. Someone that I used to work with and I, we had an agreement that regardless of how they were going or if they'd been using or drinking, we would check in on the phone every Tuesday. If by the end of Tuesday I hadn't managed to get a hold of them, we agreed that I would ask the police to perform a welfare check. Amazingly, after we made that plan, I never had to call the police, but we were able to have a more open dialogue about their use and their goals for the future, and we built a really strong working relationship. An important part of this plan with this person that I worked with was having trust in the person and the relationship we built, as well as them having trust in me and me having their best interests at heart. This isn't something that happens overnight, and it doesn't suit a one-size-fits-all approach, but it does highlight the importance of genuine rapport, even if that rapport is hard-won and takes time. Motivational interviewing is a really wonderful resource for how to approach conversations about substance use when you or the person you work with feel it's appropriate. Housing providers within Housing First programs might struggle with this more than support providers because of preconceptions around their role and systemic issues around accessing and maintaining housing. And these things often led to our clients' initial experiences of rough sleeping. But utilising a harm reduction framework alongside the other principles in this series does go some way in reducing that wariness of services. These are all really small things that I'm sure you already do. And to be honest, without systemic and policy change, there's only so far that we can go. This is where Housing First as an evidence-based approach to ending homelessness is so important. I'm just going to remind you one last time about the principles that we've covered in the last 16 weeks and remind you again that they're available on the website if you want to watch any of the webinars on them. That everybody has a right to a home, that housing and support should be separate, that people are entitled to choice and control over their lives and their housing, that flexible support should be provided for as long as they need, that people should be actively engaged without coercion, and the onus for that falls on the providers, not on the person. That we should be practicing in a recovery-oriented way, that social connection is a vital part of a meaningful life. And finally, what we've talked about a bit today, a harm reduction framework. These principles all work together to give someone the best possible chance at not just remaining housed and avoiding a return to homelessness, but also living a meaningful and satisfying life. And I think we can probably all agree that that's something we're all entitled to. I'm going to hand back over to Eleanor now.
Yeah, so this, as everyone might know, is the last webinar in our series of free fortnightly webinars about the Housing First Principles for Australia. And we've all really appreciated that everyone has tuned in and or asked questions throughout the process. One thing we'd like everyone watching to do is to just take a moment to reflect on what might have been the most useful aspect about Housing First practice that you've learned over the course of these webinars. You don't need to reply now or use any chat box function. I know it's a watching webinar, and it's just something that you might be able to reflect on in your own time. If you have tuned in for every single one of the webinars, thank you so much. It's much appreciated, and we do hope you did learn something. Yeah, any questions?
Thanks so much, Eleanor and Alice. I've had a couple of questions come up. The first question asked, at what point in my relationship with people accessing our program should I start conversations about harm reduction?
I think you're probably having conversations about harm reduction from the outset, but the really important thing is making sure you have rapport in place to start having more difficult conversations about potentially use or, you know, if someone actually wants to look at treatment for anything like that. Like I mentioned, motivational interviewing is a really wonderful way of approaching it. It's a kind of form of counselling style that ask people to look at their motivations for doing things, and it's a good way of kind of working through that stuff with people. And I think, yeah, you can just, if someone is open to it, you can kind of sense that, but also steering the conversation constantly back to substance use or you know, any other risky behaviours isn't a good way of building rapport, so you do have to be kind of sensitive with it.
Thanks so much for that, Alice. The next question that came through was, someone has asked, looking for tips and tricks for working with people who are severely substance affected.
Sure. So that might include harm reduction techniques such as safety bins, help assisting them to have a good setup in their own unit if it is a Housing First tenant, just have the safest practices possible, and obviously not to speak about it in terms of kind of stopping or really kind of giving them lectures about needing to be presenting in a certain way during case meetings, but just to really come from an angle of assisting them in the best way for them to do it as safe as possible, give them information on potentially potential services that are near them that might assist with needle exchange, that kind of thing, and just focusing on that to begin with, particularly if it's someone you're newly working with. It's just really important to build up that relationship first of all, and then it can be kind of about making techniques and maybe organizing meetings at certain times of the day that you know they might be a little less affected if there are certain things you might need to get done. If they're not a Housing First tenant, it could be things like housing applications, that kind of thing, where you know you kind of need to be together to do it. Harm reduction in that sense could be kind of arranging times to meet with that to help fit it in.
Thanks so much, Eleanor. And the final question we had coming through was, how can workers balance harm reduction principles when the behaviours are directly putting tenancies at risk, such as the cost of substance use means that rent isn't being paid?
I think Housing First isn't kind of a carte blanche to do whatever you want to an apartment and not pay your rent and still remain housed. There is an expectation that people will meet those tenancy requirements of not bugging their neighbours and paying their rent and not causing extensive damage to a place. And I think Eleanor put this really well beforehand. She was saying that harm reduction isn't about wrapping someone in cotton wool and just like, you know, allowing them to use or, you know, engage in other risky behaviours until they eventually die from it. It's about putting kind of relationships in place that allow them to delve into it. But I think you've got to pay your rent. That's not something that is negotiable.
Thanks so much, guys. That's the questions that came through today, so I'll hand back to you.
Thanks so much. I'll bring it over to Alice for our final slide, just for some thank yous.
Yes. Well, thank you everyone for tuning in or downloading later on or anything like that. Thanks to my mum for coming to this one. Thank you to also the Lord Mayor's Charitable Foundation in Melbourne, to Homelessness Australia, where Trish works. I know Trish works at the Council to Homeless Persons, which we will also thank. And also the Housing First Train the Trainer community of practice, who collated a lot of the materials in this presentation and the rest of the ones in the series. This is our last webinar, so if you've followed along the whole time, thank you so much. And if you're just tuning in, that's great too. Thank you for coming here today. And I guess we'll leave it there.
Yeah, thanks so much.